Chairperson Martin Jorilana here. So I think it's better that we will start. My name is Professor Braverman Isaac from Israel, and we will have this meeting on the role of the nose in snoring and sleep apnea. We are in the corona setting, as you know, and I think I will call the first speaker, Russell Cattract, to speak on multifactorial nature of snoring and sleep apnea. Russell is here? No. Okay, so we'll go to the next speaker, Bhick Kotecha. So Bhick Kotecha will speak about the link between the nasal pathologies and obstructive sleep apnea.
Good morning, ladies and gentlemen, and welcome to ERS 2021. I'm sorry I'm not able to be present for a face-to-face presentation in Greece, and so this is a recorded presentation. My task today is to talk about the link between nasal pathologies and obstructive sleep apnea syndrome. Greetings from London, United Kingdom. I've no disclosures to make for this particular talk. So with sleep disordered breathing, we consider the upper airway anatomy to be of great importance, and this includes the entrance of the airflow from the nose all the way up to the larynx. In fact, whatever happens to the nose will have a major impact on the retropalatal and retroglossal dimensions, which are the commonest addressed anatomical segments by ENT surgeons when looking at sleep disordered breathing. The airflow starts from the nose at the nasal vestibule, and it flows all the way into the larynx before it reaches the lung. So the nose is the first port of entry. Any factors that contribute to nasal obstruction will result in mouth breathing. And when the mouth is open, it will undoubtedly have an impact on the tongue and the soft palate. So on the tongue, because there's retraction of the mandible, and on the palate, because the airflow will be turbulent and it will exaggerate palatal vibration. When considering obstructive upper airway, one must look at the skeletal framework abnormality as well as the soft tissue abnormality. Now this is important because there is an obvious difference in the muscle tone during wakefulness and during different stages of sleep. So considering the skeletal framework abnormality, this is constant, this is static, it's not going to change. But the soft tissue will change, and it will change during different stages of sleep. So in order to understand the pathogenesis of obstructive sleep apnea, one must look at the pathophysiology of the nasal function. And to this effect, looking at the Starling resistor model, we know that there's increased nasal resistance, which will lead into increased negative pressure downstream. If you have nasal obstruction, then it will result in oral breathing. The unstable oral breathing will increase the total airway resistance, both at the level of the soft palate and the tongue, as mentioned before. Looking at the nasal ventilatory reflex, there is a decreased nasal airflow which will affect the minute lung ventilation. So this is the nasopulmonary reflex. And when looking at nitric oxide, this would affect perfusion and ventilation. It is also involved in the arousals and the pharyngeal dilator muscles. This is done through the inflammatory markers, and the endothelial function is obviously affected by this. So this interesting paper published in Sleep and Breathing in 2003, it was a review article looking at nitric oxide and obstructive sleep apnea by Haidt and Jubsland. And it stated in the very beginning that nitric oxide and obstructive sleep apnea are inseparable. There's a deep association between the two. Nitric oxide serves as a regulatory function in most tissues, and for obstructive sleep apnea, it has an impact on the efferent pathways of the pharyngeal dilator muscles. There are a number of associations with obstructive sleep apnea syndrome that are important. In patients with obstructive sleep apnea, it is thought there's going to be increased oxidative stress biomarkers. There's going to be an increase in the levels of pro-inflammatory cytokines, so like CRP and various interleukins. Obstructive sleep apnea has been associated with decrease in nitric oxide levels. And this reverses when the patient has been using CPAP therapy. So looking specifically at the nerves, we can divide the abnormalities into anatomical, physiological, or pathological. With the anatomical abnormalities, it may be valvular collapse, and this may be upper lateral cartilage or lower lateral cartilage. It may be a deviated nasal septum that's causing the congestion. It could be a fractured nasal bone causing an external framework deformity or enlarged inferior turbinates. Now, the physiological aspect could be due to either allergic rhinitis or non-allergic rhinitis, or indeed vasomotor rhinitis. Pathologically, one may encounter nasal polyps and or rhinosinusitis. So looking at nasal pathologies and obstructive sleep apnea specifically, this interesting paper from Italy by Magliulo et al., this is Claudio Vicini's unit, looked at 50 patients with obstructive sleep apnea. And they found that 70% of these patients had some degree of nasal pathology. When looking at specific incidents of different pathology, they found that allergic rhinitis was present in 18% of the patient, non-allergic rhinitis in 26% of the patient, and chronic rhinosinusitis in 6% of the patients. But they concluded that neither allergic rhinitis or non-allergic rhinitis correlated with the severity of the obstructive sleep apnea in these 50 patients. So when looking at treatment of these pathologies, it could be either medical and or surgical. And your aim here is to achieve a complete cure, or in some cases it may be an adjunctive treatment. The adjunctive treatment may be part of multi-level surgery or in conjunction with an oral appliance like a mandibular advancement device. One may also use nasal surgery to help facilitation of CPAP. In terms of non-surgical treatment, appliances to treat the nose have been described, like the nasal dilators or the nasal strips. These include alar dilators, nose-to-vent clips, and breathe-right strips. There is indeed good subjective data that it would help patients with their sleep quality, and this is actually a yardstick, because if this helps, then it may imply that surgical intervention may also help. In terms of medication, steroids, be it systemic or topical, antihistamines, nasal decongestants, leukotriene antagonists will all have a positive impact and improve sleep quality in patients with sleep disordered breathing. In terms of nasal surgery, we need to alter the structural abnormalities in order to improve the nasal airflow and also improve the resistance. It is thought that this may help primary snorers, and it may also help facilitation of CPAP therapy. And the kind of surgery that is useful is septoplasty, turbinate surgery, endoscopic sinus surgery, nasal valve surgery, or indeed external septorhinoplasty that may improve the upper airway. Here you can see that the right nasal cavity, the vestibule, is completely occluded by the valvular collapse. This patient would also find CPAP utilization very difficult. Here you can see a broad external deformity here, and a patient of this nature would benefit from having an external septorhinoplasty. This is a decongested nasal cavity showing a gross deviation of the nasal septum impinging onto the lateral wall. And patients who have this kind of abnormality would find CPAP very difficult and would certainly have issues with mouth breathing and would further exacerbate their obstructive sleep apnea. Similarly, nasal polyps at grade 2, grade 3 will interfere with their breathing, and in patients with sleep disordered breathing, if they require CPAP therapy, they will again find this difficult to use. Of course, endoscopic sinus surgery would relieve that problem. So looking at the literature with nasal surgery for sleep disordered breathing, and this lovely study in 2008 looked at 49 patients with obstructive sleep apnea and septal deviation. It was a randomized controlled study looking at nasal surgery versus sham surgery. And nasal patency in the Septoplasty group improved for certain. And using the Share criteria, which implies that the AHI should improve by more than 50% or be less than 15 per hour, 4 patients it improved but not adequately. Work done by our group, we looked at a systematic review and meta-analysis with 16 sleep studies, and we found that nasal surgery alone does not cure obstructive sleep apnea. However, there is a limited benefit for a subset of patients. So multi-level surgery is the way forward because sleep-disordered breathing exhibits a multi-level phenomenon. Nasal surgery alone may not suffice, and again a paper by Salapatas in 2016 looking at 10-year data on 600 patients demonstrated that the combination of nasal, palatal and tongue-based surgery had better outcomes than single-level surgery. Similarly, there are studies to demonstrate that any intervention within the nasal cavity could have a beneficial effect on the patients with sleep-disordered breathing who require CPAP. CPAP compliance is not great. In most studies, about 40% of the patients fail CPAP, and usually this is due to some underlying pathology in the upper airway. So this study by Michael Friedman in Chicago, looking at a small number of patients, 22 patients, performed nasal surgery alone to demonstrate that the CPAP pressure requirement in patients with mild, moderate and severe sleep apnea improved. As you can see here from the chart, in the mild group it improved from 7.2 centimeters down to 5, in moderate 9.5 to down to 6.5, and similarly in the severe OSA group, demonstrating a statistically significant drop in the CPAP pressure requirement and hence an improved compliance and adherence. Similarly, the paper by Camacho et al. In Sleep 2015, where they did a systematic review and a meta-analysis with 18 studies. Total number of patients was 279, and they concluded that isolated nasal surgery can reduce the CPAP pressure requirement significantly and therefore improve the CPAP compliance. So what if nasal surgery fails? You may then have to rely on appliances and devices. And we did some work with a device called Alaxostent. And this was looking at a nasal stent where the patients were undergoing sleepiness endoscopy to demonstrate that the stent could make a difference. This particular study looked at a nasopharyngeal stent, but you can get a lot of different types of nasal stents. And this photograph here demonstrates the nasal pharyngeal stent, where the stent is inserted through the nasal cavity and goes all the way back beyond the nasopharynx to the upper part of the oropharynx. Now, this would be absolutely adequate if the patient's got nasal congestion and palatal flutter, but would not be adequate if they had problems with the tongue base. However, the newer stents, the Alaxolito and the Alaxolito Plus, are much shorter stents, and they would fit inside the nasal cavity and improve the nasal airflow, and also has an impact on the nitric oxide levels. There have been MRI studies to demonstrate the improvement in the nasal function. So to conclude, ladies and gentlemen, there's a definitive role for nasal evaluation and treatment in patients with obstructive sleep apnea. It is important to consider both medical and surgical treatment for these patients. It has now been well documented that nasal surgery alone is rarely curative, but it is a very useful part of multi-level surgery, and in particular, radiofrequency interstitial thermotherapy is now the minimally invasive surgery that has been used for sleep-disordered breathing. Specifically in patients with CPAP rhinitis, the medical and surgical therapy for the nose would be very useful in improving the CPAP compliance. As mentioned previously with the two papers, the nasal surgery does improve CPAP compliance. But obstructive sleep apnea, it really is a multidisciplinary problem, and the treatment to it should be a multidisciplinary approach. And when ENT surgeons fail, they seek attention from respiratory physicians and vice versa. Of course, if all fails, then you could end up using the didgeridoo, which can improve your pharyngeal muscular tone and help you with CPAP. Thank you very much for your attention.
Thank you, Dr. Kotecha. I think we